so much, and good afternoon, everybody. My topic is menopause and diabetes, and I've learned some interesting things while going through the slides. So I like to tell you the highlights of the interesting things, not just go through my slides. Hmm. So what we are talking is that menopause in women with diabetes can be delayed or can be premature. So this is very interesting. Can you raise hands? How many of you think that menopause is delayed in a diabetic patient? How many of you think menopause is delayed in type 2 diabetes? And how many of you think it happens earlier? So, well, I'm going to prove that yes, in some patients it is delayed because it's very interesting that if they get diabetes, yeah, my slides are here, so I'm happy. So I'll just complete. If they get diabetes and obesity at a later age, obesity itself, so we all know that fat is not just a passive, it's an endocrine organ. So these adipocytes secrete estrogen, and menopause may be delayed in women who have adiposity and develop type 2 diabetes later. So it's very interesting, and I think I loved making the presentation, and I'm sure you'll all love listening to me. So the menopause diabetes connection, defining menopause. Perimenopause is the transition period leading up to menopause, can last several years, can start as early as 35. Menopause is the point when a woman has no menstrual cycle for 1 year. It can happen between ages 45 and 55. Postmenopause is the period after menopause characterized by ongoing hormonal changes. Now, why is metabolic syndrome common with menopause? Because in menopause, there is a decline in estrogen secretion, and estrogen levels, when they decline, this leads to insulin resistance. It leads to dyslipidemia, leads to central obesity, and it leads to inflammation, resulting in increase in pro-inflammatory cytokines. Now, this leads to obviously increase in the incidence of type 2 diabetes, metabolic syndrome, and cardiovascular disease. Menopause is now a part of the metabolic syndrome. So menopause is accepted as an indicator of metabolic syndrome in women regardless of age when they had menopause. Now, central obesity is characterized by increased visceral adipose tissue. And of course, this contributes more. And like I told you, the visceral adipose tissue is very active. Secretes pro-inflammatory cytokines, also secretes an enzyme called aromatase, which inhibits, in fact, it converts the androgens to estrogen, the testosterone to estrogen. And that is why obese women may have estrogen levels for a longer duration, and they may have delay in menopause rather than early menopause. So coming to the link, the chronological and ovarian aging, what happens? So as you age chronologically, what happens is there is weight gain. Women tend to gain weight when they age. There is increase in insulin resistance as you age, and definitely there is a reduction in physical activity. Now, with aging also comes ovarian aging. Now, what is ovarian aging? Ovarian aging means that there is a reduction in the function of the ovary, reduced secretion of the hormones from the ovary. Now, ovarian aging is decline in the overall ovarian function. Now, what happens when the ovarian function declines and the level of estrogen is less? Estrogen increases insulin resistance, thereby the patient is more prone to IGT and type 2 diabetes. Estrogen leads to changes in lipid metabolism, including increased level of LDL and a reduction in HDL. It leads to decrease in vasodilatation. And then what happens? There is increase in aldosterone, there is increase in sympathetic nervous system activity, and all these lead to an increase in blood pressure. So ovarian aging, along with chronological aging, is responsible for the metabolic syndrome and increased incidence of diabetes. Now, effects of diabetes on ovarian aging and menopause. This is what I was talking about. So just look at the last. In women with late onset diabetes who are obese and premenopausal weight gain, this might mediate the later age at menopause. However, if the patient is type 1 diabetic, there may be early ovarian aging. We all know that our type 1 struggle with fertility if they get married late, reason being that there may be autoimmune destruction of ovarian function also. What happens in a type 2 diabetic? There may be microvascular changes and reduction in blood flow to the ovaries. This leads to adverse changes in the ovaries, leading to early ovarian aging and ovarian failure. So these patients, again, type 2 diabetes, who have developed type 2 diabetes earlier, as in the at the age of 30 to 40, they may have early menopause because of microvascular complications leading to reduced function of the ovaries. So this is very interesting. Risk of diabetes after menopause. Of course, this is very easy to understand that once there is menopause, there is change in insulin action as well as change in insulin secretion and degradation. And this happens because as muscle mass decreases, triglycerides increase, there is inflammation, and all these lead to insulin resistance, and these make the patient more prone to type 2 diabetes. So the problem is the audience that neither can I see the slides here nor in my in my screen. So please bear with me. It's almost an extempore. I think the previous speakers also agree. Yeah, so I can't see the slides, so it's an extempore presentation. So I think I'm happy if I complete and take up some question answers, because I can't read the slides in any case, neither from here or nor from my laptop. Now this is again very interesting. Associated changes in early perimenopause, late perimenopause, and post-menopause. So what is early perimenopause? It means that the patient is not yet totally devoid of the patient is not yet totally deprived of estrogen. There is some estrogen secretion, but there's a reduction in the estrogen and there is a hormonal imbalance in the patient. That is perimenopause. Here the estradiol is there, you can see, and the FSH is increased, it's there, but the patient now has increase in cardiovascular risk factors, and there may be increase in carotid intima media thickness, if you see that, and there may be other changes. Now coming to late perimenopause, that means the patient is now progressing towards menopause. Now what you see is that there is a reduction in estrogen, the estradiol decreases, and now you see that the FSH in response to the reduction in estradiol increases, the follicle stimulating hormone increases, the anti-Mullerian hormone decreases, so AMH decreases. Now the body composition changes as perimenopause happens, and women find it extremely difficult to lose weight. There is increase in visceral adiposity with a decrease in muscle mass. This happens. So we know that estrogen is important for metabolism. Bone, there are estrogen receptors in the fat, in the bone. So osteoporosis now starts in the late perimenopausal state. So energy intake and expenditure decrease. And post-menopausal, of course, now the hormones are totally absent. The estradiol is absent, and the FSH now, first it will increase and then again it will fall. The body composition changes further. The energy expenditure decreases. The cardiovascular risk factors increase. The patient, because of menopause, I just told you estrogen is cardioprotective. That is why once the patient has menopause, there is increased incidence of metabolic syndrome and increased incidence of cardiovascular disease, stroke and MI both increase. Now, metabolic concerns with weight gain and cardiovascular disease. Again, this is a very interesting slide. The combination of risk factors now increases the buildup and burden of an atherosclerotic plaque with risk of plaque instability and rupture. Estrogen protects. So just see this interesting benefits of estrogen. So now the answer is, which my talk we should conclude, do we need to give HRT and what do the studies say? So I'll quickly come to those slides. What is the evidence? The association between age of menopause and type 2 diabetes. This is a study where the primary outcome was association between age at menopause and odds of developing type 2 diabetes. So this, I'll quickly go through this. So it says that both early menopause and late menopause are associated with an increased risk of developing type 2 diabetes. This is the evidence from this trial. Meta-analysis again, according to early and late menopausal age, same. These were the objectives. So again, it was found that the study confirms that type 2 diabetes significantly increases the risk of early menopause, and early menopause increases the risk of type 2 diabetes if the patient is obese. So this morbidity, majority of the diabetic women in this study suffered from micro and macrovascular complications, probably because of long duration of diabetes. And we must conclude that average age of menopause in diabetic women is 4 years lesser than the normal population. So this is important. But some of them, and early menopause was attained by 50% of the diabetics, whereas 17% of the non-diabetic women. So if you compare diabetic with non-diabetic, definitely diabetic women will attain menopause 4 years earlier than the non-diabetic women. This is important. So how do you manage the metabolic risk? So what do you do? First, you quantify the risk, then you manage. You start with cardiovascular disease risk stratification, which is you actually calculate the ASCVD risk, whether menopause is definitely one risk, cigarette smoking, other risk factors we know, type 2 diabetes, dyslipidemia, and hypertension. You manage all of those. Just one last slide and I'll finish, and that is HRT needed or not needed? What are the advantages and the disadvantages? So the trials have shown that if you start HRT early in a type 2 diabetic patient, if she has symptoms of vaginal dryness, decreased libido, and lot of hot flashes, HRT helps. But if you start it late, if HRT is delayed after menopause, as in delayed by 5 years, then there are not much beneficial effects. But it has been concluded in many trials, including the NHS, the Nurses Health Study, that HRT increases the risk of cardiovascular disease, particularly stroke and heart disease. It also increases the risk of clots, deep vein thrombosis. So HRT has lost its, luminance. And now, if we are giving HRT, we should think, and estrogen alone HRT is now recommended, not combination of estrogen and progesterone. Of course, in women who've had hysterectomy, estrogen alone can help because you don't need the progesterone in those patients. But otherwise, we have estrogen alone HRT, we have estrogen with progesterone. Now estrogen alone is used, but not for a long duration. And you do get benefit on prevention of certain cancers like colon, but otherwise HRT now is not mainly used. It's used only if the patient is very symptomatic. So I conclude by my last slide by saying that cardiometabolic health in women is very important and it deserves considerable attention. And post-menopausal women, particularly those complaining of decrease in libidos and vaginal dryness, hot flashes, may be offered short course of estrogen orally, not with progesterone, may be offered a local application of estrogen. It's available as creams for the vaginal dryness, but otherwise HRT increases the risk of cardiometabolic diseases, also increases the risk of deep vein thrombosis, but it may decrease osteoporosis if used early. Thank you.